So thanks a lot to the local organizing team, Dr. Saurabh, Dr. Gaurav, Dr. Shivam, and Dr. Kaur. So lasers. So I've been asked to speak on lasers in management of glaucoma. It's a very big topic, so I'll try to be as brief as possible. So there are no financial or proprietary interests. So as you all know that glaucoma is a group of optic nerve diseases which is progressive, it is irreversible, there is loss of the retinal ganglion cells, and the key word here is irreversible, so something which is gone forever. So laser, as we all know, stands for light amplification by the stimulated emission of radiations. So you have photochemical, photothermal, and ionizing effects. So what are the main objectives for doing a laser? We want to maintain functional vision by reduction of the IOP, angle control, and treatment of the predisposing factors. So these are the three goals that we have, and for that we have a number of laser procedures. I'll only be talking about these 5 which are more commonly preferred: the laser trabeculoplasty, cyclophotocoagulation, laser iridotomy, laser iridoplasty, and laser suture lysis. So IOP reduction is by laser trabeculoplasty, where we enhance the aqueous outflow, laser suture lysis post-trabeculectomy, and cyclophotocoagulation for reduction of the aqueous production. For angle control, we have laser iridotomy for relieving pupillary block, and laser peripheral iridoplasty, whereby we modify the contour of the iris. Laser trabeculoplasty can be either ALT or SLT, and now we also have a direct selective laser trabeculoplasty. So why? Because it is effective, it is non-invasive, easy to perform, and what it does is it increases the outflow of the trabecular meshwork. When do you want to do a laser trabeculoplasty? Either it can be done as a primary treatment, or when your medical therapy is inadequate, or also as an adjunct to your medical therapy. So what is the basic principle? The principle is selective thermolysis, whereby you have minimum collateral damage. So you decrease the IOP by increasing the aqueous outflow. And what the laser does is it shrinks your collagen, it stretches or widens the uveoscleral trabecular meshwork, and by various processes including release of cytokines and phagocytosis, it increases the outflow of the aqueous. So if you see on the left hand side, you have these small spots. These are of ALT, and the bigger ones are of your selective laser trabeculoplasty. So there are various studies which now tell us that it is very effective for patients with ocular hypertension and open angle glaucoma. So it is effective for POAG and OAT. It is as effective as topical medication, and the effect can last up to 36 months, which goes up to maybe 5 years. So once you do a selective laser trabeculoplasty, you might not need any medication for that patient, maybe for another 3 to 5 years. So this is a big plus that it has, and it is extremely safe. So what you need is, you need a laser machine, argon or a frequency doubled ND-YAG laser. You have various gonioscopic lenses. Pre-medicate your patient with anti-glaucoma. Use the gonioscope to identify your meshwork. The settings for ALT and SLT will be different. You can start with a test spot, and the power will be in the range of 0.5 to 1 millijoule. You don't need to worry about the spot size, which is fixed at 400 microns. So you can see the spot size for SLT is 400, which is almost 8 times as compared to your ALT. And you can treat up to 360 degrees. The wavelength is around 500 nanometers for both of these. So SLT targets melanin. It focuses on your pigmented trabecular meshwork. Look for the cavitation bubble, and if you can decrease your energy accordingly. And post-operatively, you can give steroids and non-steroidals to the patient. Follow-up is typically at 4 to 6 weeks. So this is how you do your laser trabeculoplasty. You identify your posterior trabecular meshwork, and then you fire. So it does have its complications, which are like transient blurring or IOP spikes, for which you've already pre-managed your patient. Monitor your IOP, and close monitoring is essential for only-eyed patients, pigmentary glaucoma, previous SLTs. So for patients who have pigmentary glaucoma, because there is a lot of pigment dispersion, you can do this procedure in 2 sittings. So for other cases, maybe you can have just 1 sitting. For pigmentary glaucoma cases, preferably you should have at least 2 sittings for your SLT. Now, laser iridotomy is one procedure which is very commonly done and perhaps the most common among all these. So what it does is it gives you an alternate pathway for the aqueous to pass into the anterior chamber and relieves your pupillary block. Therefore, the indication is relative pupillary block in any condition. It could be acute, it could be your PAC, PACG or SAC. It is again effective, non-invasive. What are you doing essentially is that you are puncturing the iris, as you see here, and it relieves your relative pupillary block. So what you need is again an argon or an ND-YAG machine, and nowadays you can do both your laser iridotomy as well as your SLT on the same machine by various companies. It is better to do it with an Abrahams or a Weiss lens, which gives you better visualization, stabilizes the eye, and you need to use lesser power. It is not advisable to do your PI at 12 o'clock. Better to do where the iris is thin in an iris crypt, and 11 or 1 o'clock positions are preferred, although you can do it at 3 o'clock and 6 o'clock also. Sometimes you might need to do multiple iridotomies. So don't worry if one iridotomy is not working. It might be a good idea to do another, depending on the patient, of course. And of course, use minimal energy. There are 2 ways of doing it. For thicker iris, you can make a bed, and subsequently you can do the ND-YAG laser. So the settings for the green and the ND-YAG laser will be variable, and the energy for the ND-YAG laser is in the range of 2 to 5 millijoules. But I have seen that many of our patients in Indian eyes might need much more higher energies than this. So this is how you can do a laser iridotomy, and you focus with your aiming beam. This is a YAG laser. Your aiming beam is focused onto a peripheral area, which is a thin crypt. Do not go too peripheral because the iridotomy may not work then. And you can see here that there is a sudden gush of aqueous which has come out, along with blood which can come at times as well. So what is the end point of your PI? It is the release of pigment and fluid into the anterior chamber. You are able to observe the anterior lens capsule. You can also do an aiming beam test. Remember that transillumination may not be the best method for checking the completeness of your PI. The size should be at least 100 to 150 microns for it to work. The complications could include temporary blurring, corneal burns, IOP spikes, and you will need to monitor your IOPs and always repeat your gonioscopies as well. Now, when to do a PI is that the ZAP study has shown us that for PACS, it is not recommended for these patients. And remember that you should know your machine, choose a thinned out iris script, and indent the cornea. If there is significant bleeding, it will stop in most of the cases. Sometimes when you have two steamy corneas, you are not able to do a primary PI. You can do a laser iridoplasty. Again, it is non-invasive and is useful, for example, in plateau iris. Again, the requirements are pretty similar. A spot size here is much bigger at 500 microns for half a second. The power will be in the range of 100 to 200 milliwatts, and 10 to 40 spots is what you should be aiming at. Again, post-operative steroids are needed in this case also. Cyclophotocoagulation is done by a transscleral diode laser with reduced aqueous production for painful non-seeing eyes where surgery is not appropriate or where the surgeries have failed. So your exposure time would be 1 to 2 seconds with a power of 1 to 2 watts, 20 to 40 burns over 180 to 360 degrees at 1 to 2 millimeters from your limbus. It has certain complications, is painful, so you can give pain medication beforehand and give topical steroids and cycloplegics after the procedure. Avoid your 3 and 9 o'clock positions. Then you have laser suture lysis. Since the time is up, I'll just skip to my last slide. So you should know your machine, practice gonioscopy, and communicate well with your patients. So lasers can be used in glaucoma treatment to achieve several goals: reduction of IOP, angle control, and treatment of predisposing factors. Laser trabeculoplasty to increase outflow, iridotomy to relieve pupillary block, cyclophotocoagulation to reduce aqueous production, iridoplasty to contract the iris, and suture lysis to avoid bleb failure after trab. So this is a first case where you have a 40-year-old female with acute painful diminution of vision, colored halos, IOPs high at 24 and 38 with shallow ACs, a diagnosis of primary angle closure in the right eye and PACG in the left eye, and this is a typical patient who needs a laser iridotomy. Then you have another patient of pigmentary dispersion or with ocular hypertension, and these patients are good candidates for doing an SLT, and this can be done as the primary procedure as well. So thank you for a patient hearing.